we are live now, but we'll start sharp at 7. Yeah, Dr. Amulya, you can switch on your camera now. Yeah, allow me to say a few words before we let you start. Thank you very much on behalf of IAPS and on behalf of President IAPS. I would like to thank you for accepting this webinar on the platform of IAPS. And to all our viewers, thank you for joining for this webinar. And there are a lot of viewers, Dr. Amulya. There are people, apart from people across India, there are people from Middle East, Algeria, and various other countries. And we'll get to know as they start commenting on the YouTube chat platform. We have already nearly 50 viewers on YouTube, and people are eagerly waiting for your presentation. So, friends, we have Dr. Amulya. He will be presenting on duodenal atresia and the endoscopic approach. So, without any further delay, I will hand it over to Dr. Amulya to start with his talk. We will have the question and answer session at the end of his talk. And please keep posting your questions on the YouTube chat window, and we'll keep a note of that. And Dr. Amulya would be very happy to post his questions. Thank you, sir. Please go ahead.
Thank you, Dr. Ravi, for inviting me to this webinar. And I would like to thank the Indian Association of Pediatric Surgeons also for this kind invitation to help in further education. The topic today is going to be duodenal atresia and the endoscopic approach, something which I feel is of importance, especially with this surgery now becoming more prevalent in most of the countries. When you look at the progress made by pediatric endoscopic surgery over the years, in the 90s, we started with diagnostics that moved to taking care of ovarian cysts and appendicectomies, which were done in the late 90s also. This then gave the impetus to pediatric surgeons with the miniaturization of instruments to perform fundoplications, splenectomies, and colorectal procedures. The next thing that we started doing was congenital diaphragmatic hernia repairs, and hepatobiliary procedures were also taken in the armament of pediatric surgeons. This was followed by esophageal atresia repairs and approach to lung malformations thoracoscopically. The last of the published data comes on duodenal atresia repairs, as this was considered to be one of the operations to be performed in newborns and a technically difficult one. When you look at the type of duodenal atresia repairs, there are three types of atresias, and it is important to understand that in the context of the endoscopic repairs. The type 1, as you can see, is a membrane or a web which causes the intrinsic duodenal obstruction. The type 2 is a complete obliteration with the proximal and the distal portions attached by a fibrous cord. You have finally the type 3, which is a complete separation of proximal duodenum from the distal duodenum, just held by a fibrous structure. What is very important in endoscopic repairs is also where the hepatobiliary tree ends into the duodenum. The presumption is very difficult to make because, as you can see from the images, it can end into the proximal pouch, or it could even end in the distal end. It could even bifurcate into both the sides. This is very important, especially when you do endoscopic repairs. After you open the proximal pouch, notice if bile is coming out from that side, or when you make the slit into the distal end, if you have bile coming out from that side too. Now, the principle of repairs is not something new. It is absolutely common to the Kimura repair, which is done in open surgery. So endoscopic repair is not a new technique. It just replicates the open repair, and it is done with some type of modifications or technical modifications, which are important and which I will share with you in this lecture. Now, the most important thing is the placement of the patient. And in my opinion, the best placement is towards the end of the table or the bottom of the table with the legs of the baby crossed. I prefer to use a 3-port technique, and my preference is for a 5mm camera. I do not prefer a 3.5mm camera. I think a 5mm gives you a good quality of vision. And 2 ports, each of 3 or 3.5mm on the side, are sufficient for the surgery. There is no need to bring in extra ports or for this kind of procedure. Now, the instruments for endoscopic repair are very important. My preference is to have 2 endoscopic needle holders. I prefer an endoscopic scissor and a feeding tube, which I will mention to you the reason for this feeding tube and why it's important to have it on the table at the time of surgery. And sutures, my preference is generally for 5-0 suture. We will go into the different suture materials and find out why there is no preference for a certain type of material and why I would prefer to use the other types. What is very important, and at this time of the lecture, I would also like to mention that repairs are also being done with stapler now in duodenal atresia. So the 5mm stapler is now being used to do the repairs. That means that you do not have to do a lot of suturing. You can just put in the stapler and just have the 2 ends anastomosed and just close up the opening of the stapler. This talk is on the repairs which are done conventionally using the suturing technique, as staplers are not available in most of the countries and they add an additional cost to these repairs. Now, the most important thing when you start and you have your instruments and your ports inside is to optimize the exposure of your operating or surgical field. In my initial series, I started suspending the gallbladder, put a hitch stitch of the gallbladder and attached it to the abdominal wall. I found that this was not a great idea because in case there was a tear in the gallbladder in a newborn, you had to end up repairing that and also contend with the bile leaks. From this point, I moved on to the suspension of the falciform ligament, which also helped to show the entire area of operation or the area of interest. And finally, my present technique, which I will show you a couple of slides, is the suspension of the proximal segment of the duodenum. So I do not suspend anymore the gallbladder or the falciform ligament. I directly suspend the proximal pouch of the atretic duodenum. Now, this is a laparoscopic view of the proximal pouch. As you can see, you have to remove the peritoneum on top of it and just try to grasp it. The proximal pouch, as most of you know, is a quite dilated structure and quite easy to find once you proceed with the laparoscopic instruments. As you can see, my preference is to directly pass a hitch stitch from the abdominal wall, pass it through the proximal pouch and hitch it up so that I have a good view, and I do not do any more falciform ligament hitches or the other hitches which I mentioned previously using the gallbladder. This is a view of a laparoscopic repair of a duodenal atresia, where you can see this is the proximal pouch. You have the annular pancreas sitting very nicely in between the two ends, and this is the distal end of the duodenum, which you can very clearly identify on this image. The proximal part and the distal end, which is nicely seen. Unfortunately, in live, you can see the entire pancreas a little bit more orangish in color, which is very clear and distinct. Now, there are some technical considerations, especially when you do laparoscopic approach. The most important is to mobilize and approximate the distal segment before you open it up. Sometimes you will find it is quite difficult to bring the distal segment up for an anastomosis. You do not want a tension in the anastomosis. So unless you're not sure that the distal segment is coming up, do not open it up, because then you have two open ends and you are in trouble, as you cannot do the anastomosis, which is tension-free. There is an option for that, which we will also go through later in the lecture. I always use scissors to incise the proximal and distal segments and completely avoid electrocautery. It's a simple and the same principle when you do esophageal atresia repairs. You do not electrocauterize. You make an incision in the proximal pouch and you make an incision in the distal pouch. One reason for not using electrocautery in incising the upper pouch or the lower pouch or the lower segment is that you cause burns in these structures, which may interfere once you have put the stitch together and cause leaks, because the scarred structure may not heal well as a fresh structure which is incised. The other important thing is to rule out a distal web and an obstruction beyond the atretic area. Now, this can be done with a couple of technical tips, which I will share with you in the next few slides. Now, once the two structures can be approximated, as you can see, this is the distal segment, this is the proximal segment. I put a hitch stitch just through the proximal segment and the distal segment to bring and approximate both these ends together. After the approximation, an incision is made with the scissors. I do not mind the small amount of bleed that you have using the scissors in the proximal pouch. This is followed by an incision in the opening of the proximal pouch and an incision in the distal pouch. This is the incision of the distal segment, which is also done with the scissors, longitudinal incisions, similar to what you would do in open surgery. The problem at this point is, and which I noticed after completing a couple of cases, there's an immediate drop in abdominal pressure, and this is from the leak in the NG tubes. So if you have an NG tube, which all these children have till they come to the theaters, please ask your anesthesiologist or your colleague from anesthesia to spigot that tube. You will see that that definitely helps and the loss of pressure is not there. In the first few patients, as soon as we opened the proximal pouch and the abdomen just fell down, you were not sure that nothing had been done. You just opened the pouch and you had a loss of pressure. So spigot the NG. That is very, very important to prevent loss of pressure and for you to proceed with the procedure. The second thing is try to pass the NG through the true enterotomies. That is the proximal enterotomy, which you have done on the proximal pouch, as well as the distal incision. This is to rule out a distal web. Now, passing this tube sometimes causes a lot of problems because the tube, when the anesthetist tries to pass it through the proximal pouch, curls up back into the pouch or in the stomach. It's very difficult to retrieve that tube through the proximal pouch incision. So the other thing which I've done, if I cannot retrieve that tube through the proximal pouch, through one of the ports, I pass in a feeding tube. This, of course, the feeding tube is spigoted because you do not want any loss of air. And after that, you just pass it through the distal portion of the atresia just to make sure that you are not having a distal web. The other thing, what I also do is I pass and retrieve all the sutures directly through the abdominal wall. I do not try to straighten the needles, do not try to push them through the ports. They're pushed straight through the abdominal wall, retrieved in the abdomen. Once the surgery or the sutures are done, the sutures are passed back through the abdominal wall. Now, as you can see, the posterior wall is first sutured with 2 or 3 sutures on the back, and this is followed by the suturing of the anterior side of the to complete the anastomosis, which is also done, as you can see in these images, with PDS. There is an advantage in PDS that I find it quite easy in tying the sutures with that. But of course, because of the shape memory, when you use the suture in the abdomen for 2 or 3 times, the shape memory may sometimes you might find it difficult to hold on to the suture. Vicryl may work as well as PDS, so it could be your choice. And we will go through the choice of different sutures and what is the evidence that we have today in regards to these different materials. As you can see, the anastomosis of the anterior side is done. I prefer interrupted sutures. So interrupted sutures are passed and the complete anastomosis is performed at that point. I do not pass any TAT tubes or transanastomotic tubes. I just leave it as it is. The tube, if it is passed by the anesthesiologist to confirm the distal web, which is passed through the proximal pouch, is retracted back and placed in the stomach, and that's it. Now, we have quite frequently, as you know, patients that have duodenal atresia are also patients who have Down syndrome and malrotation. In the beginning, I used to presume that malrotation may add a more complex approach to duodenal atresia repairs. But in fact, over a period of time, I found out that malrotation, in fact, makes things quite easier in duodenal atresia repairs. As you can see in this patient, the appendix is just below the liver on the side. That's the colon. You bring the colon on the side, and in case of a malrotation, you have the distal segment just right in front of you at the same time. So you do not have to go and search for the distal segment on the other side as you do in a traditional patient with a normal lie of the duodenum. As you can see, the proximal pouch is again stripped clean so that you can have a complete exposure of the proximal pouch. A hitch stitch is put on the proximal pouch to hold it on the top. You can see the distal part of the duodenum just below that, which is brought up, approximated, very easy, and the anastomosis is commenced. On this image, you can see the distal part of the duodenum being brought up. There is no tension, and you can just do the anastomosis quite easily in cases of malrotation. So these are ideal cases in which you do not have to run or chase behind the duodenum while you try to do the procedures. Now, is duodeno-jejunostomy an option? Because I mentioned to you before, always approximate the distal end of the duodenum and try to bring it to the proximal pouch. And if you have a lot of tension, it might be difficult because your anastomosis will be under a lot of tension at that point. In the literature, when you see the first successful repair of duodenal atresia was reported in France in 1905 by a person called Vidal, who performed a gastro-jejunostomy. So he did not even attempt to do anything with the duodenum. He just bypassed the stomach with attaching the jejunum to that. Later on, the first successful duodeno-jejunostomy was performed in Denmark. And incidentally, this is very interesting that somebody called Ernst, who operated this patient in 1914. This patient was followed 61 years later on in 1975 and was found to be of good health. So gastro-jejunostomy, we do not prefer that, but if you have trouble finding the second part of the duodenum, I just do a duodeno-jejunostomy in these patients. Very easy to mobilize the jejunum, bring it to the pouch, proximal pouch, and just do the anastomosis in that case. The double diamond anastomosis, as you know, was advocated by Kimura in 1977. So over the years, people have been doing other procedures until 77, when the pediatric surgical community embraced on the double diamond anastomosis. Now, something which is very important, and the analysis of what we are doing today and why we are doing that, we have to carefully analyze the outcomes. So what we did was we studied laparoscopic repair of duodenal atresia through a meta-analysis in which we did the comparison with open repairs. What we did also in this analysis was we compared the operative time in open versus laparoscopic approach, time to establish feeds and discharge, and the port size, suture materials, and type of suturing. So, and comorbidities, that means Down syndromes, cardiac anomalies, and malrotations. The other thing, and the most important thing, was first we compared between laparoscopic repair and open repair was the rate of complications. This study showed us that there were no significant complications, overall complications, whether you did a procedure laparoscopically or open. So the overall rate of complications were same, and that was very encouraging because people anticipated endoscopic repair or laparoscopic repair to be a more difficult technique, and of course to be associated with more rates of complications or leaks or strictures. We went further into the analysis, and something which was interesting was found at this point was in the laparoscopic repairs, there was less time to establish full feeds in the patients, although not significant, but it was less. The other thing, the laparoscopic patients, there was a lesser time to discharge from the hospital versus open repairs. But what did not favor laparoscopy at that time was laparoscopy took a significantly longer time with regards to repairs when you compare that to open times. So only significance which we found at that time was a longer operative time in laparoscopic procedures. The next analysis which was done was the overall complications in laparoscopic repairs. Now, to answer that question, and I told you my preference was for PDS and Vicryl, we looked at all the different studies which use silk, Vicryl, and PDS. We did not find that any of these materials was associated with any increase in complications. I mentioned to you my technique was of interrupted suturing. Running suturing and interrupted suturing was also compared, and there was no difference in the overall complications found when you used either of the techniques. The other thing what we analyzed was the port size used in treating these patients, 2 or 3 millimeter ports versus 4 or 5. Again, there was no difference in the overall complications. So as far as your choice of material goes, as far as your technique is going and your size of ports are going, there is no overall difference irrespective of which type of port or material or suture technique that you choose. When we tried to compare conversions for laparoscopic approach to open, we found that the rates were not, again, significantly affected by the suture materials. So we thought some suture materials might give more problems, and that's why there might be conversions, but that was not found in any of the studies. Different suturing material, suturing techniques, that means either you did a running suture and you were converting, or you did an interrupted and converting, that was not there. And the port size also did not cause the conversions to open repairs while using laparoscopy. Now, when we look at the reasons for conversions and complications, there were, in these 124 patients, there were 22 conversions. And I looked carefully into what were the reasons of conversions. Is it because of the technique or some other reason? And it's important to do an analysis so that these problems are not repeated. Poor visualization. And I mentioned to you, for poor visualization, the most important thing is once you get the upper pouch open, you have this gas leak through the NG tube, which can cause collapse in the abdomen. The other thing is also to secure your optic port quite firmly with a stitch or a hitch stitch on the skin, so that you can use the optic port to pull back and give you a little bit more visualization while you do these procedures. In one patient, there was a concomitant TOF in which the conversion took place. There was a distal atresia, so a second atresia was found, and the authors for this paper preferred to have a conversion. There was one thermal injury, one malrotation, and a little bit, the type of malrotation was not exactly described, but as I mentioned to you, the malrotation cases are much easier to operate because the distal part of the duodenum is just lying in front of you. 7 of the papers did not mention the reason for conversion. When you look at the complications, there were 20 complications, which is close to 16%. In 5, you had an anastomotic stricture, and this is a point which is very important to keep the end of your needle holder to estimate the size of the incision that you made in the proximal pouch, as well as the distal segment, so that you have sufficient anastomosis size. A very small anastomosis will just shrink, and you will get the problems like an anastomotic stricture. Anastomotic leak in 5 cases, and this was one of the biggest problems or the hindrances in endoscopic surgery, especially with advanced suture tying techniques, that anastomotic leaks would be a big problem. And I think this is also a part of the initial series. As you see, this meta-analysis was done in 2017, so it basically took into account the series that were reported between 2004 and 2013 and 14. Severe gastroesophageal reflux was a complication in one of the patients, one missed duodenal web, and that's what I, again, informed you, use one of the tubes or NG tubes to pass it through the distal part of the segment to make sure that you do not miss a duodenal web. In one patient, there was a prolonged ileus for 20 days, but I cannot explain that as a part of the endoscopic procedure and endoscopic repair. One patient had an incisional hernia, and there was one cardiac complication. So I would just like to summarize the endoscopic repairs, that the complication and the conversion rates in laparoscopic repair of duodenal atresia are unrelated to the port size. That is, you could use 2 or 3 millimeter or 4 and 5 millimeter ports. This will not affect your procedure. The choice of suture material, and this has been a big question of debate among a lot of surgeons, are their preferences to use that. The meta-analysis shows that you could use either of the materials. Like I said, my preference would be for placing the sutures with PDS, and then if you prefer Vicryl, it's absolutely fine because Vicryl is non-shape memory and you could use it for the suturing. Suture technique, anastomosis, I find it easier to do interrupted sutures. People have done running sutures and they're absolutely fine. If you prefer that, you can go ahead with that. I just feel that in running sutures in my hands that I might leave a little bit gap and might have a leak. So that's why my personal preference is for interrupted sutures, but the meta-analysis shows that there is no difference. Now, there is an advantage with laparoscopic repairs in terms of time to establish full feeds and early discharge. This has been definitely shown in a lot of studies, and recent studies that have come out with the stapler also have shown these advantages. The only disadvantage with the suturing technique is that the laparoscopic repair was significantly longer in operating time than conventional repair. I'm sure if you do a meta-analysis, now that a lot of groups are doing duodenal atresia repair, I'm sure that this number will go down. And if you compare it with the stapler technique, of course, expensive and not available everywhere, the 5 millimeter stapler will be definitely comparable to that of open repair. So I would like to then conclude this talk that duodenal atresia has variations and are often associated with malrotation. As you know that you have patients with Down syndrome, and in these patients you can find a malrotation at that point. And of course, for me, I find them much easier to repair. At the same time, if you want to do a LATS procedure, it can be done in the same sitting. You have to incise both ends of the atresia with scissors. As I mentioned, avoid electrocautery, as that could damage the ends. And while you do the anastomosis, you could have leak possibly because of the scarring of the edges due to electrocautery, and difficulty in the anastomosis later on. Distal web should be ruled out using NG tube progression. Like I said, you could use the already in place NG tube pushed by your anesthesiologist, but sometimes it's very difficult as it curls in the abdomen. So it's better to take a second tube and push it down the distal segment, and also at the same time make sure that you do not have a distal duodenal atresia. If approximation of the segments is difficult, I'm saying it's difficult in very, very few cases. In most of the cases, you will be able to mobilize the difficult segment and be able to perform a duodenostomy. In case you're in trouble and you're not able to get it for whatever reason, the child or the baby being too small or the neonate offering you some technical difficulties, go in for a duodeno-jejunostomy, which I've also done. And the laparoscopic approach requires a good level of suturing skill. You cannot learn during this procedure. You have to be proficient in doing neonatal laparoscopic suturing before you try these duodenal atresias. I thank you very much for your attention, and I will take some questions.
Yeah, thank you. Thank you, Dr. Amulya. Can you hear me now?
Yes, I can hear you, please.
Yeah, can you exit the screen share now? Yeah, now we can see you full screen. So thank you. That was an excellent talk. Much enjoyed by all the viewers, almost 135 in number in YouTube at the moment. People across Pakistan, Bangladesh, all the SAARC countries, Oman, Middle East, Algeria. And so everybody enjoyed. There is a huge round of applause for your presentation. There are a bunch of questions which I will pass on to you now. So duodenal atresia coming to your place is by default you will apply the laparoscopic approach to all these babies, or do you have a particular selection criteria for doing the laparoscopy or open in other set of patients?
Well, as you know, we are a laparoscopic center. So by default, laparoscopy is something which we will do in almost all the cases. Unless a child has a cardiac problem, which is identified by the anesthesiologist. And as you know, we work very closely with the anesthesia colleagues. So they will flag down to you and say, look, I think it's quite risky if you go in with a laparoscopic approach in this child. So in this case, you take an open approach. So your nurses might be surprised because they know that you only do it laparoscopically, and then you come and tell them, no, we have spoken and we'll do it open. So they have to close all the laparoscopic equipment and bring it back again. So the only concerns for me, even now, is there was a paper which came out from Glasgow quite some time ago in duodenal atresias, which shows that the outcomes are a little bit different in very, very low birth weight children. So this is some cutoff area which we need to really identify. What is the cutoff that you will not do a duodenal atresia? At the present moment, I would not prefer to do it under 2 kilos for anesthetic concerns or the other concerns. And also based on the Glasgow paper right now, 2 kilo plus would be my approach for duodenal atresia.
Sounds very fair. And so you spoke about the possibility of using staplers in the duodenal anastomosis. Can you elaborate on the type of stapler? Is it the Just Right surgical stapler which you're talking about?
Yes, that is the 5 millimeter Just Right stapler, which is being used now to approximate. So you make both the incisions, you approximate the two ends, just fire in the stapler, and just close the end of the area where you put in the stapler. Now, the stapler technique also will go through its refinement. If you saw last year at the European meeting, there was a presentation in which one of the staplers, I don't know if it misfired or there was a leak in this patient. They had to go back in again in this patient. Or the end of the stapler perforated through the distal segment. And these complications have to be again weighed in how small the child is. I'm sure that the stapler technique is a good technique, but then you have to have the added costs of the stapler in your department to do this. So that's why I stuck my lecture to the traditional way of putting the sutures, which is available everywhere. The staplers, as you mentioned, they may or may not be available everywhere with the Just Right. But yes, it has shown advantages. There's multiple suturings. You can get them done with just one stapler application and then close the initial entry point with 2 or 3 stitches. as with all the techniques, refinement happens, and there is no point in sticking to a technique. Over a period of time, we might find that the stapler may be the gold standard. So it's good to keep an idea and an open eye that this technique is also being practiced.
So Dr. Manisha is asking, what precaution do you take to avoid injury to ductal opening, especially if there is some anomaly of rotation or something like that?
The most important thing is to just stay as proximal or as much as you can see the structures in front of you. So try to make an incision not in the tapering end of the pouch, in the middle area of the upper pouch. That is very important. Do not come down and do not extend your incision on either sides. What you're seeing just in front of you, you will not have a duct ending in that front portion in front of you. And the distal part, also make the incision and make a cut as you go down. Do not start very close to the atretic area. And that's what I tried to show you. I put one hitch stitch in the beginning before I even start opening. So that area very close to the atresia is just weighed off. So I'm 3 or 4 millimeters anyway away from that area before I even make the incision at that point.
Stitch which you're using, are you using Proline or some other suture? This is asked by Dr. Shankar.
Well, I'm using PDS. The only thing which I enjoy with PDS, I can slip it much easier to get the two ends together. So that is the advantage. But what I saw in multiple uses of PDS, with holding the suture again and crushing it repeatedly, the suture loses its strength. And the other thing, because it is shape memory, every time you try to use it, the shape memory gets the suture moving in one side or the other. So Vicryl would be a good option after you've just stabilized the two ends with the tension suture. So it's absolutely up to you. My preference is both. For if I want to use multiple times the suture, Vicryl is a much better option.
There is a question about the incidence of duodenal atresia in your region, because now with increasing antenatal diagnosis and increasing termination with the anomalies, the incidence is gradually going down at all the major centers. So is it the same experience with your place, or it is different?
I don't think we have any termination of pregnancies because of duodenal atresia or these problems, or even as far as I know, with even syndromes, that the termination is not as much as I would expect. Cardiac anomalies also, we are able to manage these cardiac anomalies. So I think there's a steady flow of duodenal atresia patients throughout the year, and even with fetal anomalies and fetal counseling, what we are involved in fetal counseling. You have to sit down as a surgeon, assure the parents that this child has only duodenal atresia, or the child is already Downs with a cardiac condition. So we will manage this part. So I've not seen any of the patients, at least that we have refused or the termination because of these anomalies. So I think the rate is almost the same, and fetal counseling has not decreased anything like that.
Yeah, because in the Indian area, it's little different, because if you have a diagnosed duodenal atresia or an associated syndrome with that, diagnosed before 20 weeks of gestation, usually they are counseled for termination unless it's a precious child. So that is a little different from your area. There is a question about the excessive dilatation in the proximal duodenum when you anastomose. Sometimes there is a problem of an adynamic segment in that part of the duodenum. Would you do some kind of plication or tapering in that part to tackle that?
No, I'm not a very big fan of tapering. And the reason is I try to avoid too much manipulation in the proximal areas, that you might damage something which is probably just lying behind that, any kind of ductal structure. So the most important thing, if you find a huge dilatation, of course, it is not going to return to normal. It has taken an insult over a longer period of time in the fetal age. So when you have these massive dilatations, you can just have a good size incision, which is with a longer anastomosis. So if traditionally, how do you measure the anastomosis? You place your instrument and the area where you've incised, so you have an approximate idea. So at least an anastomosis, or an incision, should be 1 to 1.5 centimeters, then you do the anastomosis. Yes, you're right. All duodenal atresia babies do not recover at the same rate. There will be some that will take more time to start feeds, and that's why there was this huge concept of transanastomotic tubes, or pushing the NG tube below that so you can start feeding immediately. I'm not a big fan of pushing the TAT tubes through the anastomosis or keeping a TAT tube, because in another series we found out that there were complications, as this can cause also perforations. So you just take time, and you might have to have some children longer on TPN until you get back to full feeds.
Yeah, here, since TPN is not readily available in every hospital and the costs are a big concern, the TAT tube is really a priority with majority of the people practicing here. And yes, I agree that sometimes TAT tube can lead to complications like perforation, but people are doing it. I think there are papers from India about transgastric anastomotic feeding tube or through the nasal route also. In your experience, what is the time to the first oral feed, average time for these patients?
Well, I am a little bit more fast-tracked person, so I do not mind that the child starts feeding 24 hours after surgery. And there are a couple of reasons for that. One is you've done the anastomosis in an area. As soon as you finish the anastomosis, there are gastric juices pouring over it. There is bile pouring over it. Nothing can be more aggressive than that. So if you have to have a leak, by this time you will already have it. It's like having a cut on your skin and pouring acid from the very first moment. So I would like to prefer to start feeds in 24 hours. It depends on how the child recovers from anesthesia, how the intensive care colleagues would like to start it off, but no restrictions. We wait for NG aspirates to go low. Once the NG aspirates go low, that is a good indicator to start. So my biggest change in thought came from David van der Sey when he informed me that they had a case of duodenal atresia in which one of the registrars just fed the child accidentally on day 1 of surgery. Of course, the surgeons were totally in shock because you cannot do a major laparoscopic course on day 1 with feeding, but the child did very well. And from that point, they changed their approach to starting early feeds, and I think that works absolutely well.
You spoke about the possibility of distal atresias, and there were a few patients in the meta-analysis also, which you mentioned. So do you actively look for distal atresias in these patients? And some people will do it by pushing some air or fluid through the TAT tube and then look for the distal atresias. Is that recommended?
Well, I push in a tube. I push in an NG tube inside the distal end, and on the other side, it might sound a little bit cumbersome, but I make sure that I see the NG tube by lifting the colon on the DJ side. So whether you have the DJ flexure, I try to see. If you're having problems, you can put in a small squirt of air, but don't put too much, because then you have dilatation of the intestines and that might create problems in your repair. So generally try to push the tube, you will get it through, but air is something which might just get you into trouble for the procedure.
Dr. Bipin Puri raised a point about the duodeno-jejunostomy, but I think he was asking about the long-term prospects and the outcome of these patients. But I think you mentioned it that there was some 65-year-old patient who was doing well. So yeah, that answers his point. And yeah, I think we're done with the questions. Dr. Rahul is asking experience of late presenting duodenal web, whether you manage them by laparoscopic surgery or endoscopic management. Nowadays, people are actually perforating the web and dilating it instead of operating.
As far as I know, that the endoscopic approach in a late presentation is the choice, because when you have one of these, and if you have good endoscopists or who can just puncture the web or just go through that, of course, there's a risk of creating a perforation in these procedures also. So you have to keep that in mind. Yes, endoscopy would be the first line in any center. And then if endoscopy doesn't work, then you start going with a surgical approach with this thing. Of course, depending on the location of the web, you can decide if you want to go in for the laparoscopic approach or not. But these are generally in the second to third segments of the duodenum. So just you want to see how much you want to go laparoscopically, but endoscopic is the way most of them have been managed, at least in the centers that I've worked.
So there are general comments about laparoscopic surgeons being able to handle neonatal laparoscopy during their procedure of the learning curve and their training part. So is there some kind of module where would you go and say that now this particular trainee of mine is ready to attempt a neonatal surgery before you give him that particular opportunity?
Well, something which I found which was very important, and people underestimated that, was in the beginning, we almost all our trainees do appendicectomies. But in appendicectomies, as you know, there is very little suturing and knot tying. If you use endo loops or whichever technique you use, so the level of skills that you train your trainee on that is very, very little. So in our hospital, at least, all the neonatal inguinal hernias from 2.5 kilos or 2 kilos are all done laparoscopically. And depending on which registrar is with you, and once they start working with you, so of course you give them the opportunity to put the stitch or put the suture and tie the suture. And you can judge by your registrar's level how good this person is when you're doing a duodenal atresia. Now, the most important thing in duodenal atresia, yes, you give the stitch to the registrars to do it, but make sure that you've covered the back wall securely. That should not fall. If you keep having a rupture in your duodenal atresia of stitches falling apart, then you might go into the dangerous area and you might have some more injury. So make sure that you have the first few stitches or sutures placed behind. The registrars can place all the sutures in the front comfortably, and just keep controlling that the sutures are sitting well and being tied completely the way you want it. You might have to alternate putting every second suture, but I think you can recognize after 1 or 2 months working with registrars who have the competency level, yes, you let them go ahead with that.
I think a good place to start would be the lap pylorotomies, where they can handle a small baby and the ergonomics inside the stomach.
I agree. The lap pyloromyotomy is again a challenging procedure. It's not to be underestimated, although people think that it's just a simple incision. And there was a very nice paper from Amsterdam that says at least you need to do 50 lap pyloromyotomies so that you have the confidence level. Each one of us knows that lap pyloromyotomy is technically a simple slit, but it involves the spreading, which is very difficult to estimate. You don't want to overspread it. It's just that 1 millimeter difference that you can have a perforation, or you do not spread it enough and you have an incomplete myotomy. So also laparoscopic pyloromyotomy, yes, you can do that, but be sure that you are there and you're taking the responsibility when the registrar is doing it.
I think there are no further questions. So I would now thank you on behalf of IAPS, on behalf of President IAPS, Dr. Partha Pratim. There are a lot of other senior IAPS members who are thanking you, and a lot of other people across the world who are appreciating your talk. So we hope to have you on more such sessions on the platform of IAPS webinars.
Thank you, Dr. Ravi, and my greetings to all the IAPS members and colleagues in India. And stay safe during the pandemic right now. It was a pleasure to be with all of you today.
Yeah, thank you. So we'll end this now. Thank you so much. Thank you all.